Everybody for joining us. This is the first of our research mini reviews, continuing on the tradition of last year and facilitated by the COVID fact that we can't actually meet anyway, so we're ahead of the curve. The topic tonight is all about bowel cancer, something unfortunately we have far too much of, and a lot of challenges in providing the service that we need to our community. We're very grateful to have two outstanding speakers this evening, Tim Price and Joanne Young, and we're kicking off with Tim, who's needs no introduction. He's well known to us all, is an oncologist and heads the oncological research group, particularly down here at the Queen Elizabeth. And tonight's talk is bowel cancer in 2022, more than one disease. Tim, the floor is yours.
Thank you very much, Guy. So yes, I thought I'd talk about the clinical research program that we are involved in at Queen Elizabeth and through the Basil Hetzel Solid Cancer Program Group. And my theme is bowel cancer, and it's more than one disease. So why is it more than one disease? So when I started, well, 20 years ago now, it was quite easy to recruit patients to colorectal cancer studies. They were all the same, and they'd all go in, and we'd recruit large numbers. But that's changed an awful lot over the last few years, and that's partly because of our molecular understanding of the subgroups of colorectal cancer. And this slide really just highlights that. We now have a number of molecular predictors or pathways that give us a guide as to the best way of treating patients, and that has come from clinical trials, but it's also then made clinical trials more complex. And the ones that I'll focus on, just giving you some examples of what we've been involved in recent time, is the Braf mutations, which is around 6 to 10% of colon cancer, the RAS mutation group, which we're making some advances in recent time, which is the largest group at 50%. And then a very rare subgroup, the mismatch repair deficient, or the microsatellite instability population, which is around 4% or so of metastatic colorectal cancer. And there's some others there that I won't cover, but site of primary we know is important. HER2 in colon cancer is also now important in terms of predicting or guiding us in terms of treatment options. I put this slide up briefly, really just to flag or highlight that the treatment pathways for colon cancer, therefore, are now more complex. So out of the clinical research we've done, we now have to think about a number of different subgroups that then guide us as to which treatments are actually commenced, so the first-line therapy and then the subsequent pathway moving forward. So it's not just one single pathway anymore. And as I alluded to, I'll focus on the bottom two in red there, which we've been doing some research. So the first trial I wanted to highlight, which we were involved in, large international trial, but we were involved in at Queen Elizabeth, is the Keynote 177. So this is based on immunotherapy for the mismatch repair deficient subgroup, so the 4% of colorectal cancer. I'm sure you're aware of the use of immunotherapy in melanoma and lung cancer and others, but in GI cancer, gastrointestinal cancer, it's actually quite uncommon. And that's because the tumours are not sensitive to the immunotherapy, aside from this rare subgroup, so the mismatch repair deficient group. So this is a large international study looking at quite a different approach. So single agent immunotherapy, so getting away from chemotherapy for this population, and randomising to standard of care, which of course is chemotherapy with a biologic, depending on the subgroup of colon cancer. So this was a large study. We recruited only a number of patients to this study, reflecting that these trials are now difficult to recruit to, and you need multiple centres to be able to get to these results. So this result, I think, is really compelling, and it's probably one of the highlight of the ones I'll show you. So this is a population you can see on the survival curve there, in the sort of reddy colour, the normal progression-free survival. So it heads down towards the bottom. Patients ultimately all progress. So in this deficient mismatch repair population in green there, you can see a quite different and unexpected, I guess to a degree, a progression-free survival curve. And importantly, around 50% of patients at 2 years had not progressed. And this is very unusual, as you probably know, for metastatic colorectal cancer. So this is truly hitting the mark. And reflects a population within the colorectal group that is sensitive to immunotherapy. The waterfall plots on the right tell you that even with single agent non-chemotherapy, you also see significant response. So you also get tumour reduction. So even things like converting to surgery, for example, will still occur with single agent immunotherapy in this patient population. So the downward slope there of the waterfall plot is the responses, and if anything is better than chemotherapy. So this trial, large study, has now led to pembrolizumab, which is the immunotherapy in this study, being a standard of care and available on the PBS for patients as of early this year. So again, an example of what research achieves. We've now seen a change in practice. The other study I wanted to talk about was focusing on the BRAF mutation group. So this is about 10% of colorectal cancer. This is the reverse. These patients do very badly. So their survival is typically in months rather than years, as we see for some colorectal cancer. And attempts to treat this group have been focused on the BRAF mutation with BRAF mutation targeting drugs. But unlike melanoma, when you target BRAF, what you actually get in colorectal cancer is a blocking of the upregulation pathway to the EGFR, and you then get overactivity and then downflow through the EGFR pathway, and in fact potentially ongoing activity with that blockade. So what you need to do is actually block BRAF and the EGFR so that you get a true block of the EGFR pathway. So this is a study that we're involved in. Again, we randomized a reasonable number of patients to this study, but again, it's a relatively small group, so 1 in 10. And this was looking at a non-chemotherapy option. So this is a BRAF inhibitor and an anti-EGFR inhibitor, that's the encorafenib and cetuximab, and comparing it in a randomized fashion to chemotherapy and anti-EGFR therapy, which also we know is not particularly effective. So even binding the EGFR receptor alone in BRAF mutation does not work. So what we saw here was particularly on you can see the survival curves. So these are overall survival curves now. And again, this reflects the poor outcome. So if you compare them to what I showed you before, which were progression-free survival for a different subgroup, here we're seeing overall survival. So for the standard of care, 6 months roughly, which is short, as I'm sure you'd agree. And this has improved out to around 9-10 months with the combination therapy. So this is again a non-chemotherapy approach, purely molecular, based on an understanding of the cancer. And you can see that there's an improvement, but probably not as impressive as the previous study. So hitting the target, signal and improvement in survival, and enough again to change practice. So this is now also available on the PBS for this subgroup of patients because of this survival advantage. But just the red dot there, if you can see on the left survival curve, is what you would expect for a patient who did not have the BRAF mutation. So that's a survival out around 14-15 months. So again, telling us we need to do more in this patient population moving forward. And then I wanted to talk about the KRAS. So I mentioned this was 50% of colorectal cancer. So this group has not had any improvement for the last decade and is the largest group. But what we now see is there's increased complexity because there are subgroups. So there are different types of RAS mutation. And what we now have are agents that target G12C. So the particular KRAS mutation G12C, which is around 3% of colorectal cancer. So although it's a big group, within it are again small subgroups, and you need large numbers to do these studies. This is a key phase 1 study, phase 1/2 study that we were involved in with AMG 506, which is a specific G12C RAS inhibitor, mutation inhibitor. It's a fairly successful phase 1 study, both for all cancers with this particular mutation, and then the colorectal cancer published recently in Lancet Oncology. This is the colorectal, again, the waterfall plot, and these are patients who have had multiple treatments, so we don't expect them to respond to therapy. So these have had chemotherapy, antibodies, etc. So what we see here is a signal. We see some responders in patients who shouldn't respond. So again, we're hitting the target with a specific drug, but this is very much at the end stage. And what we now need to do is move this agent into earlier lines of therapy to have a greater impact. Now, I should add that, again, we see differences between different cancers. So the non-small cell lung cancers with this mutation actually do significantly better than this. So again, we need to differentiate what actually the target means. And so we may need to use combination therapy and colorectal therapy, for example, rather than single agent. But we get a signal anyway from this study. So what are the studies we're doing moving forward? So they're studies we've done, they're changing practice. So we're expanding what we do. So the BRAF mutation population that I touched on. We're now moving that into early line therapy with chemotherapy. So that's the breakwater study. We're recruiting patients to that trial, so further expanding that target. The G12C population, we're doing additional studies, as I alluded to, in earlier lines of therapy. We're also looking at different ways of immunotherapy in patients who are not mismatch repair. So that's the 007 study that I've highlighted there. And the other thing that I didn't touch on, which is also changing practice, is looking at circulating tumour DNA to guide us as to when we might change or use these molecular targets. So we can look at the BRAF and RAS and etc. in the liquid biopsy, the circulating tumour DNA, and actually make decisions around these treatments. These are ongoing or upcoming studies. So again, we've got very much an engagement in the G12C space, looking at different combinations, different phases of therapy. And then there are some other trials coming through, again, looking at novel targets. So FGFR2B and broad RAS inhibitors. So really reflecting the change in the way we look at colon cancer and the different trials and the different subgroups. So just to finish, so what are the directions of our group with taking this into account, and I guess the opportunities? So bowel cancer not being one disease, my theme. So we now have small subgroups. Clinical research needs to have a different strategy in that setting. The crossover of these molecular targets also tells us that we don't need to, or we shouldn't be thinking about necessarily bowel cancer as the only disease. So these targets actually work across gastric, pancreatic, endometrial, for example, for the mismatch repair deficient group. So we have a drug that works, but it's actually probably for the target, not the disease. So what we've done in our translational sort of group with the solid cancer group in the Basel-Hetzel is move away specifically from bowel cancer and looking at a more broad platform, and it's a so-called agnostic approach. So moving towards more the target than the disease itself. Not to say that colon cancer is still not one of our main interests. And then the opportunities, well, we're involved in these large studies, so we have the opportunity to maybe pitch novel projects. The sponsors of these studies are very keen to have investigators have ideas and potentially put them forward to look at other subgroups, other definitions of populations who may be treated differently. And through these collaborations, we also have access often to the research material, so we can bring that back to the laboratory, to the Basel-Hetzel, and do additional studies through these collaborations. So these trials are very important, change practice, and I guess also help us with our future research needs. And so with that, I just want to thank the group that I work with, the clinical trials unit, the units at the Basel-Hetzel, and I'm open for questions. So thanks, Guy.
Yeah, no, look, thank you very much, Tim. It's becoming so complicated. It was very easy once. Look, I haven't actually picked up any questions on the chat line. Tell me, you know, these new PBS agents that have now become available, what's the sort of cost of a treatment? Give us a feel for what we're spending on these to gain 3 months of extra life.
Yeah, so as a community, and I think that's an important point, but particularly the difference between those first two studies I showed you. So there was quite a difference. I mean, the immunotherapy, the pembrolizumab benefit is really quite compelling. I mean, some of these patients are actually cured from immunotherapy. I have a patient who was on the study who's now 4 years out. They had 2 years of immunotherapy, 2 years off. She had a complete response. So she's, you know, that's remarkable for metastatic colon cancer. Immunotherapy, though, as we know, to the community is very expensive. It's, you know, I think 60, 70,000 a year for maybe be a little bit more. It's really quite expensive. But of course, being on the PBS, that's not the cost to the individual. But yes, they are costly drugs. But that said, I mean, immunotherapy is common for melanoma, lung cancer, etc. So for those results I showed you, it's really compelling to have access. BRAF group, I mean, that's where it gets a little bit more difficult because those, as you said, 3 months shift in overall survival. It is smaller. Again, those drugs are quite expensive. I think they're about 10, 12,000 for a month when they were on an access scheme prior to, patients were paying for that prior to the PBS. You know, that's where it starts to get a bit more difficult, and you do want a bit more, so bang for your buck, so to speak. So that's why those trials that follow on with different combinations are going to be very important to maximise that benefit. But yeah.
And when these drugs are being prescribed, you are tightly constrained by having the right markers to treat them with, or is there a bit of off-label use?
No. I mean, look, I mean, but no is the answer. So you would, but you know the evidence. You know there's no point. Immunotherapy does not work if you don't have deficient mismatch repair. So there is no benefit to the patient in doing that. So yeah, no, I mean, I suppose I'm speaking from myself, our unit, but I truly believe there's not a lot of off-label use in the Australian setting. I think we work with the PBAC. Yeah.
Well, Tim, thank you very much. It's a great talk, and I mean, it is going to get a much more complicated disease to manage, and I guess the other thing that will happen is, I mean, you are constrained a little bit by the markers you have. There'll be more markers found, which will again open a whole lot of other potential cocktails that were previously thought to be useless.
Well, exactly, and even that the RAS group. I mean, we've considered RAS mutation 40–50% as a group that we want to target, but we'll probably have 5–6 different RAS mutation drugs for each particular one. So it does make things it will make things interesting. But the recruitment to studies is difficult because you've got such a small subgroup, so they become a rare disease. And so we need to think about that very differently in terms of funding and the support for trials, etc. Yeah.
We could spend all day talking about it. Thanks very much, Tim. We're now moving to Joanne Young. Joanna's one of our outstanding scientists here, based at the Queen Elizabeth, with an illustrious career. And I saw today that her H factor is 86, which is unbelievable. Well done, Joanna. I will certainly come to you for more guidance. We're going to hear from you today, though, in your work on bowel cancer, looking at towards bowel cancer screening in young type 2 diabetics. The floor is yours.
Thank you, Guy. So I'd like to talk about one of the factors that could be involved in our increasing incidence of young adults developing colorectal cancer. So I'll just give a brief introduction, then I'll talk about how colorectal cancer is related to type 2 diabetes, both in the cancer form and the polyp form, and then summary and conclusions and where we might go with this. So most of our work is based around SAO, which is the South Australian Young Onset Colorectal Cancer Registry. We established this, Tim and I, in 2015. At the Queen Elizabeth Hospital to seek explanations for this increasing incidence of young onset colorectal and subsequently appendix cancer in South Australia. There's currently no definitive cause for this rising incidence, but of course much speculation about inactivity, obesity, eating fast food, etc. It most likely is multifactorial. We enrol adults aged under 55 years with cancer or significant polyps. It's a biobank and database, and it is statewide. So, we have been known to drive out to all sorts of places to interview patients. We screen for genetic disorders, diabetes, family history, lifestyle and symptoms. We have now 308 patients enrolled. 95% of them are ethnic Europeans, and we have an 88% participation rate to full enrolment, which is rather extraordinary. And I think it's because of our personal approach. We sit down and have a face-to-face interview with them, and we also check medical records for all of our validations. We also do colonoscopy audits to look at young onset neoplasia in the general population. So this rise in bowel cancer in the young is not only happening in South Australia, it's also happening internationally. And it's been associated with a simultaneous decline in the incidence of colorectal cancer in older people. And this is due to population screening. It's been a great success. However, in SAO, we actually don't use 50 years as the cutoff, we use 55. Because not only are the under 50s non-screening, the 50 to 54 age group are very low screening. Less than 1/3 of them will send back their screening test. So they are also in a bit of trouble. There's increased mortality in USA figures for the under 55s with bowel cancer. And also there is an increased risk of colorectal cancer in type 2 diabetes under 55. The two important risk factors for colorectal cancer are age and family history. And screening is offered to people in the population who are at increased risk. And our first-line screening for asymptomatic patients in Australia is the fecal immunochemistry test, and all of us who are aged 50 and above will know all about the little presents that come in the post every 2 years. And what this does is detects microscopic human blood in the stool. Now, why did we pick diabetes? It's extraordinary when you sit down with patients, what you learn. Is patient number one, I was writing up her family history, drawing the chart up, and I said, so what is your family history of bowel cancer or other cancers? And she said, absolutely none. So this young girl is 27 years old. But she said, but there's diabetes everywhere. And I wasn't going to ask anyone about diabetes. And because of that young woman, patient number one, it's really changed the whole direction of what we plan to do. So type 2 diabetes has been consistently associated with about a 30% increase in risk for everybody for bowel cancer. And this is thought to be due to the increased insulin levels, particularly in the prodromal stage, type 2 diabetes. And a couple of years ago, we tested 90 of our young onset bowel cancer cases and 240 controls with clear colons. And we found that young onset bowel cancer was clearly associated with type 2 diabetes. In the general population and the clear colonoscopy controls of the Queen Elizabeth Hospital, 5% were diabetic, type 2 diabetics, whereas 19% of the young onset bowel cancer patients were in fact type 2 diabetes. So the odds ratio was over 4. Now it may seem a little high, but we do enroll to age 54, and we also very well characterise our patients. So we do actually extra blood tests so we don't miss anybody. So it may be higher than reported elsewhere. However, this paper came out around about the same time with tens of thousands of patients from the Swedish Cancer Registry, and their cumulative risk for colorectal cancer was in fact 3.5, so very close to ours. And this risk is commensurate with that of having a family history of colorectal cancer. Additionally, if you've got a diagnosis of type 2 diabetes before age 50, you have a median age of bowel cancer of 59. So you've got some time to prevent this. And also those with both things, a family history of colorectal cancer and diagnosed before 50 years with type 2 diabetes, have a 7-fold increase from this study of bowel cancer, which is extraordinary. So we know that colorectal cancer arises mostly from 2 different types of bowel polyps, and this gives us a chance to prevent it by taking these things off. Adenomas are the most common, and serrated polyps. And so we had a look at a colonoscopy audit at the Queen Elizabeth, 1,400 patients, to see whether type 2 diabetes was in fact associated with one or other of these polyp types. And we looked at this in a rather detailed way, and we were very fortunate to have the medical student James Kimber helping us out with this. We found that evidence of type 2 diabetes was present in 18.4% of all the colonoscopy patients. And 1/3 of our colonoscopy patients at the Queen Elizabeth were aged under 55 years. And it was quite clear that adenomas were highly associated with age, with male sex, and with type 2 diabetes, but also with occult bleeding. So occult bleeding predicted whether people would have adenomas in both the under 55s and the 55 and overs, which gives us some confidence that the routine test that's used to screen bowel cancer patients will pick this up. So we had to obviously do a multivariable analysis with all of those things, age, sex, diabetes and bleeding. We did not have smoking history on these people because it's not recorded in many of the charts that we looked at. And we found that all of these things independently predict adenomas, including type 2 diabetes. And this also occurs in the under 55s. And that's what we were looking for. So we've got a strong association with bowel cancer in the young, and this has been confirmed internationally. And now our polyp information that we've picked up has also been confirmed internationally. So it's fairly clear that young adults with type 2 diabetes are at an increased level for colorectal cancer and adenomas. And this is commensurate with older age groups in the national screening cohort. And as I said before, people with a high enough risk are offered bowel screening as part of the National Bowel Cancer Screening Program. So young adults with type 2 diabetes may well be acceptable to be taken into the National Bowel Cancer Screening Cohort. So also in our young onset patients, the fecal immunochemistry test predicted adenomas independently of age and other factors. So what we would like to do, and we're proposing to examine the feasibility of screening young adults with type 2 diabetes and having them listed on the National Bowel Cancer Screening Program as a routine through Medicare. And to do this, we are working with the Jodie Lee Foundation and the National Bowel Cancer Screening Program to look at young diabetics at the Queen Elizabeth and Lowell McEwen Modbury Hospital diabetes clinics. One of the things I would like to point out here is, and this is a problem that arises all the time, is that we are using type 2 diabetes as a risk marker rather than a risk factor, in that we are not setting out to prove causality here. Clearly, there are other things highly associated with diabetes, such as inactivity, visceral adipose tissue, all sorts of things like this that, you know, just generally being fat and inactive for the young people. However, we have this marker rather than factor that we can use to identify people who are highly at risk. So the basic difference between a risk marker and a risk factor is that the marker is a variable that is associated with a disease. However, the risk factor are thought to have a causal role in the development of the disorder. So the other problem we have is there's a lot of diabetics. How do we know who amongst the diabetics is at the highest risk? And perhaps that we can persuade them to have screening. So let me get this thing to go. So one of the parts of our study will be not only to screen the diabetics, but also to have a look at, in these young diabetics, do they also have a family history of type 2 diabetes, like our patient number 1 did, and or colorectal cancer? What are their ages of onset for them and their relatives of type 2 diabetes and colorectal cancer? Are there polyps in the relatives? And one of the things that really interests me, was there gestational diabetes in the parents? Also, does hemoglobin A1C level affect your risk? And there's some controversy about that at the moment. So in summary, there is a link between type 2 diabetes and colorectal cancer, and this has long been recognised. However, we've identified it quite clearly in the young, not only in the cancers, but in their precancerous polyps of a specific type, and it's the most common one. But there's no specific guidelines in use currently to screen diabetics at non-screening ages, and this has resulted in limited impact on clinical care and outpatients for these young people. FIT tests predict adenomas in young adults, And we also have this development time. There's a long dwell time in adenomas of about 10 years. And that would allow time for us to screen and prevent colorectal cancer in these young diabetics. So we propose that young diabetics represent a group where the screening of them for colorectal cancer is likely to be efficacious. And I would like to thank the students, James Kimber and Rhaegar Mikhail, for their work on this project. Also, everyone in the Department of Medical Oncology at the Queen Elizabeth, my boss, Professor Tim Price, who you just heard speak, my research nurse, Megan Horsnell, and database manager, Wendy Ulaki. The SAO participants themselves, it's just amazing what you learn when you go out and talk to them, sit down and look at their family histories, and collaborators we have all over South Australia, and also the Cancer Council South Australia and the Hospital Research Foundation, who've given us some funding to help our research nurse do her work. Thank you.
Thank you very much, Joanna. That it really is fascinating. I don't have any questions at the moment on the chat. Can I just ask you, first of all, what happens with type 1 diabetics? Is diabetes a factor at all? Because you sort of suggested it wasn't, or is there some information about type 1 diabetics?
Type 1 diabetics show no association whatsoever with bowel cancer. It's the surging insulin in the prodromal stage that is probably the top contender at the moment. There's evidence in fruit flies that this causes a lot of epigenetic changes. So it's the high insulin levels, because the colonocytes are highly sensitive to insulin. They have insulin growth factors on them. And this may be what makes the polyps grow in the first place. But we have no definitive evidence as yet. But type 1, nothing.
Right. And you sort of, actually, I've got a chat question here. Thanks, Joe. Is there any evidence that metformin is protective in your cohort?
I haven't looked at that. I understand that metformin is protective from the literature, but I've not investigated that.
Right.
Because a lot of these young people are not on treatment, and they're like newly diagnosed or undiagnosed diabetics.
The other thing you touched on, and again, it's just all about, cause and effect and risk or marker. Obesity, is that a feature of most of your young diabetics? I mean, certainly I would think it is, but
yes.
Or is that not a big factor?
Well, that would have been my perception when I started doing this. And it's quite distressing to have a young man sitting in front of you who's really thin and runs marathons, and he's got diabetes and he's got bowel cancer. And I have seen a few of these now. They're not all fat. They're nowhere near all fat. One of the problems with recording their BMI is that they often present late. So we may be getting weight loss from that, the fact that they've had cancer for a few years. So it's probably more important is what we do ask them is, how active were they as teenagers? How active were they as young adults? Whether they played sport or not. But it is very hard to make a judgment when someone comes to you as stage 3 or stage 4 cancer as to whether their weight was a factor. But being able to look at one aspect of metabolic syndrome like this is at least giving us a marker.
No, that's right. I've always thought marathon running is bad for your health, and I'm glad you've confirmed that for me. Look, on that note, we've gone a bit over time, but there were 2 really great talks. Really interesting stuff. It's a complicated disease. But, I thank you all for being here. I thank you for coming, and I bring to your attention there is another one of these sessions next week. And we'd very much like to have you all there, and perhaps let people know that we're back on air yet again, and that maybe that they'll be able to squeeze it into their programs, and everyone's a lot more familiar now with zooming in. So Tim and Joanna, thank you very much, and we'll look forward to seeing you all next week. Thank you.